Hello everyone, my name is Anush and I'm a fourth year medical student. And today I'll be giving a crash course on anemias. So before we begin, I want to let you know that this presentation, I've tried to keep it all high yield things, and I want you to pay specific attention to everything that's in bold and everything that's in a red box, because it has been indicated by the doctor. Okay, now let's begin. So our objectives for this course is classification of anemia, iron deficiency anemia, anemia of chronic disease, megaloblastic, hemolytic, and the molecular bases. Okay, so first of all, a patient comes to you and you decide to do a CBC panel, right? So this is what a CBC panel will look like. I made it small because it's not really important for you to get into the depth of this. So let's see, what do we look at first? So first of all, we look at the RBC characteristics. We want to know the hemoglobin, which is very important. I've added the normal ranges, but Dr. Rehan said that they'll be provided in the exam. Okay, so then we look at the mean red blood cell volume, which is MCV. That basically means the size. If it's microcytic, which means it's small, or it's macrocytic, which means it's big. Then we have these two words. So when I was doing the heme-onc block, I looked at these two words and I was like, what does this even mean? So let's get into it. So anisocytosis basically means variation in size, which means some of them are really small and some of them could be big, small, and so on. Then we have poikilocytosis. So that just means the shape. So it could be teardrop or it could be sickle shape and so on. Now, what I want you to remember is anisocytosis goes hand in hand with the RDW, which we'll talk about. Then coming to mean cell hemoglobin, which is the MCH. That's basically the weight of hemoglobin in the RBC. Then we also have MCHC, C standing for concentration of hemoglobin in the RBC. Then we have reticulocyte count. Now, reticulocyte, what is a reticulocyte? It's basically a precursor, which is a step before a mature RBC. So it's characterized by RNA remnants. So we can see in this picture, we see these blue dots. Now, this is under a cresol stain, and the blue dots represent the RNA remnants. These are slightly bigger, and they're bluish, and that's called polychromasia. Okay, secondly, we look at the other things that are present, like WBCs. We see if there's any neutropenia, leukopenia, and so on. Now, what is anemia? Anemia is characterized by low hemoglobin, which is very important. All anemias have low hemoglobin, low hematocrit, low RBC count. Now, clinically, anemia is diagnosed when a person has low HB. But will this help us differentiate between the different types of anemia and classify them? No, it will not, which is why we need other things. Now, so what I want you to take from this slide is the things that we look at first is HB, MCV, MCH, and we can classify all of our anemias based on these three things. Okay, now let's talk about MCH. We said it was a weight of hemoglobin in the RBC. If it's normal, it's normochromic. If it's low, it's hypochromic. But there's no such thing as hyperchromic. You can't add too much hemoglobin in an RBC because it's just going to burst. Then we have MCHC. Now, one thing I want you to remember is that MCHC cannot be used to classify the different types of anemias. But I want you to remember that it's high in hereditary spherocytosis and in autoimmune hemolytic anemias. We'll talk about how to differentiate between them a little bit later. Now, coming to the RDW. We talked about RDW and we said that it's the size variation, right? So if the RBCs are similar, the RDW will be low. And if they're different in sizes, it will be high. Now let's do two random questions that Dr. Rehan gave us in the lesson. So first we have a 5-year-old boy. He has repeated jaundice and his blood smear shows clear spherocytes, right? So what's the next step when you say clear spherocytes? It's spherocytosis. So we'll run the appropriate test for it. So first of all, I want you to know that every single time a patient comes in, you do a CBC panel, you look at the HB, MCH, and MCV. If they're all low, it's iron deficiency anemia. Okay, now let's talk about this case. A 20-year-old male, his CBC shows low HB, MCV, MCH, which I said was iron deficiency anemia, right? So now we need to find out if it's iron deficiency anemia or thalassemia minor. And how can we do that? We can do that with the RDW. If the RDW is low or normal, it's thalassemia minor. If it's high, it's iron deficiency anemia. Okay. Now coming to classification. There's two types of classification tables. Now, this is the easier type. So let's go through it step by step. So I said MCV and MCH are very important, right? So MCV and MCH, if they're both low, it's microcytic hypochromic, okay? That would be iron deficiency anemia, thalassemia, anemia of chronic disease, and so on. Then we can also have macrocytic, which is too big, right? So MCV would be greater than 95. You don't really need to know the value, so you're good. But macrocytic would be in megaloblastic anemia, which is something very important I want to remember. Or in non-megaloblastic causes, it could be in alcoholics, liver disease, myelodysplasia, aplastic anemia, and so on. Normocytic, normochromic is everything that cannot be put into these two tables, okay? So many hemolytic anemias are normocytic, normochromic, anemia of chronic disease, acute blood loss. Remember, acute, not chronic, okay? And then we can also classify anemias due to the underlying mechanism. So it could either be blood loss, hypoproliferative, or hyperproliferative. Okay, now let's talk about what hypo and hyperproliferation mean. So it basically means the reticulocyte. So if there's a low reticulocyte count, it's hypoproliferative, okay? Now imagine you have a hyperproliferative anemia. How do you further classify it? If it's low MCV, it's iron deficiency. If it's high MCV, it's vitamin B12 and folic acid, which would cause what? Megaloblastic anemia. So if it's normal MCV, it could be renal failure or aplastic anemia. Now, if we have high reticulocyte count, which means hyperproliferative, it's basically that the bone marrow is being stimulated to make RBCs, right? So this would be the case in acute bleeding. For example, someone has acute blood loss in a road traffic accident. They got injured, they're bleeding out. What would happen? So the bone marrow will be signaled to make more RBCs to compensate for the loss of blood. So it would start increasing its reticulocyte count, okay? Then we can have physical trauma, hemolysis as well. Now, one thing I want you to remember is in anemia of acute blood loss, initially the hemoglobin is normal. Why? Because there's no problem in the bone marrow, there's no problem in the person itself or any nutritional deficiencies. It's just that he's bleeding out, right? So initially the HB will be normal. And then eventually, 2 to 3 days later, the reticulocytes will increase because the bone marrow will now know and realize that it has to make more RBCs to compensate. Then in chronic blood loss, we have hypochromic microcytic anemia. Now, chronic blood loss is mostly due to a GI pathology like ulcers or a GI bleed, any sort of it. And that could be in the esophagus, in the stomach, anywhere. Okay, now let's move on. So I said hypoproliferative anemia is when the bone marrow fails to produce enough RBCs. Okay, the reticulocyte count is low because why? The reticulocytes are a step before the mature RBCs. So there are different types of these. There's nutritional anemia. Nutritional anemia could be because of iron, B12, and folate deficiencies. All of these are replaceable, which means that if you supplement your diet with these iron, B12, and folate, you can basically fix the issue. Okay, then we have anemia of acute or chronic inflammation. Now, in acute or chronic inflammation, what happens is there's high hepcidin. Hepcidin, I'll talk about it a little bit more eventually. So hepcidin, what it does, it traps iron, so it causes decreased iron availability, and it decreases RBC production, okay? Then we have anemia of cancers. So basically, there's bone marrow infiltration, or it could be cytokine-mediated suppression. Then we also have anemia of renal failure. In renal failure, there's decreased erythropoiesis, okay? So the bone marrow is not stimulated to make more RBCs. And then finally, we have aplastic anemia. Now, one thing is very important that I want you to remember is that in aplastic anemia, you have pancytopenia. Pan meaning all of the cell lines. Now, all of the cell lines will be decreased. So RBCs, WBCs, platelets, everything. Now, I've seen a trend where they ask you, what's the difference between iron deficiency anemia and aplastic anemia in terms of reticulocyte count? Now, The difference is that in aplastic anemia, the reticulocyte count would be almost none. Like it would be so much lesser than in iron deficiency anemia. Now let's talk about hyperproliferative. So we will talk about hemolytic anemias here. So hemolytic anemias are where RBCs are destroyed early, okay? And that increases the production by the bone marrow. These could be hereditary, like thalassemia, sickle cell disease, or it could be acquired, like autoimmune hemolytic anemia. Okay, now let's talk about hypochromic microcytic anemia. Now, hypochromic microcytic means MCV is low, MCH is low. So we know it's either IDA or thalassemia minor. So how do you differentiate between this? Now, you can differentiate it based on the pictures, pictures are very important because it will come in the OSCE and in the MCQs. Now, how do you differentiate if the pictures are not given? You look at the RDW. I said RDW is size variation, right? So RDW is going to be high in iron deficiency anemia. Why? Because the bone marrow will produce a mix of small and normal RBCs. So in iron deficiency anemia, iron levels start dropping gradually, right? There's stages to this. So at first, the bone marrow is making normal sized RBCs. As the iron gets lower and lower, it starts producing smaller microcytic RBCs. And then let's talk about thalassemia minor. So in thalassemia minor, RDW will be normal or low. Why? Because it's inherited and all RBCs are uniformly small, which means it's an inherited genetic condition. So from the get-go, all of them are going to be small. Okay, now what do you do after the RDW? You check ferritin. Why? Because if ferritin is low, we can confirm iron deficiency anemia. So by now we know that ferritin is a storage form of iron, which is very important to remember. So if the RDW is normal, what's the next step? You do hemoglobin electrophoresis. Now, the test you run for thalassemia minor to confirm is HbA2. If it's greater than 3.5, it's thalassemia minor. Now, one thing I want you to remember is that HbA2 is not HbA1c. HbA1c is glucose. This is HbA2 for thalassemia minor, and it's blood, okay? Please remember this. Please do not get confused. Okay, now let's talk about presentation. So all of the anemias will show up with pallor, okay? The patient will come in and he will be pale because he does not have enough oxygen supply because his RBCs are decreased and so on. Now, what are the characteristic features? So in IDA, you'll have koilonychia. So koilonychia is, you can see my nail, it goes normally, right? It's like a U-shaped, okay? In koilonychia, what happens? It starts going outwards from the edges, okay? It's a spoon-shaped nail. In megaloblastic anemia, the patient will have a beefy tongue. In anemia of chronic disease, it's mostly after ruling out other pathologies. Sickle cell anemia, the patient will have bone pains. It could also present as a sickle cell crisis, which we will also talk about. Then we have hereditary spherocytosis or autoimmune hemolytic anemia. These are hemolytic anemias, which means there's RBC destruction, and that's why we'll have jaundice. Okay, now let's go to a question. So whenever you look at a question, I want you to just skim it and just focus on the main points. So a 63-year-old presents with fatigue. The fatigue has been developing for several months. He reports being constipated over the past few weeks. He has a family history of colonic adenocarcinoma. When you see this, it's a very big red flag. Now his HB is 10.3, MCV is 71. So based on this, we can say that this patient has iron deficiency anemia. The patient is scheduled for a colonoscopy. He has a mass, which is later found out to be invasive adenocarcinoma. So now we know this is iron deficiency anemia. What will the lab testing show? It's going to show decreased ferritin because ferritin is a storage form and it's going to be decreased. Then it will be decreased serum iron and increased TIBC, total iron binding capacity, which is the same as transferrin. Okay, now let's come to iron absorption and regulation. These were a few slides that I absolutely hated when I was doing Hem-Onc, so I will try to simplify it as much as possible. So first of all, iron is absorbed in the duodenum. Okay, this process, there's export by ferroportin. So the iron export is done by ferroportin. So the ferroportin allows the iron to leave the duodenum and go into the blood, right? Now, ferroportin is also present on macrophages, and they store iron as ferritin. So storage form of iron is ferritin. Okay, now let's talk about the transport. So basically, iron uptake is done by this right here. It's DMT1. It's basically a pH-dependent transporter. It's located on the duodenal brush border. This is the brush border right here. Okay, so that's all you need to know from the absorption area. Now let's go to regulation by hepcidin. So what exactly is hepcidin? Hepcidin is secreted by the liver and it controls ferroportin. So it controls the channel of iron export, right? So hepcidin, the function of it destroys the ferroportin channel if the body iron is too high. Okay, I want you to remember this, it's very important. So if there's low body iron, that means that our body does not have enough iron, the hepcidin is basically inactivated and the ferroportin channel is open. The iron is absorbed and then it binds transferrin and it goes to the bone marrow for RBC production. Now coming to high body iron, I said that in that case, hepcidin rises, ferroportin is destroyed, and you'll see that the absorption is blocked. Now, iron deficiency lowers iron-dependent enzymes, okay? And this increases the risk of bacterial infections. I want you to remember this, and it's very important. Okay, now let's talk about iron overload. So, iron overload can happen in beta thalassemia major because patients get frequent transfusions. And that can develop long-term iron overload. And in this case, we give chelating agents. One thing I want you to remember is that the regulation is done by hepcidin. So hepcidin levels can help prevent iron overload. Okay, now coming to causes of iron deficiency. So it could either be a problem with an intake or it could be a problem with absorption. So intake, we could have poor diet, children on carton milk. It's very important to remember carton milk, okay, because these are not supplemented with iron. However, if a child is fed on breast milk, he will not be developing a deficiency. It could also be an absorption problem, like I said, so that would be in the case of celiac disease. It could have flattened GI mucosa, and that would reduce the uptake. Now, either it's an intake problem or there's loss, right? So it could be due to bleeding, it could be hemorrhage, chronic blood loss, or it could be menorrhagia. Now, it's very common for females to develop iron deficiency anemia. Why? Because there can be menorrhagia, excess bleeding from your menses. Now coming to increased iron requirement. So iron requirement is increased in pregnancy to prevent neural tube defects in the baby. Now, one thing I want you to remember is in Saudi Arabia and in developed countries, GI ulcers are more likely the cause than an infection or an infestation. However, everywhere else we have hookworm infestations, okay? What they do is they attach to the intestinal mucosa, and this is mostly the ileum, and it can cause chronic blood loss, and that can develop into a iron deficiency. Okay, now how do they present? So let's talk about diagnosis first. So we said MCV, MCH, and HB, they're all low. So the next thing you do is ferritin, because it will help confirm your suspicion, right? Now, I said that in females, it's common to have iron deficiency anemia. Is it common in males? No, it is not. So if you ever see a male with iron deficiency anemia, what you need to do is look for a GI pathology, okay? So you do an upper-lower endoscopy or stool occult blood, because it could be an infection. Colon cancer has to be ruled out because it's the biggest red flag, okay? It's in males. Now, what do they present in? I said pallor. Every anemia comes with pallor. So pallor, fatigue, dullness, or irritability. In children, it's failure to thrive, frequent infections. Now, we talked about infections a little bit before. So in iron deficiency anemia, there's a decrease in iron-dependent enzymes in the neutrophils. What are these enzymes? Cytochrome A, B, C, catalase, and lactoperoxidase. These are very important to remember. Now, what happens to your nails? We talked about koilonychia. I have attached a picture right here. And there's flat and brittle nail. And remember, koilonychia is spoon-shaped nails. Then we have pica. Now, pica is when people eat strange things like non-food substances. This could be clay, sand, cement, or ice. In severe cases, we can also have cardiomegaly and congestive cardiac failure. Okay, now let's talk about diagnosis. So we talked about ferritin. So ferritin is a storage protein, right? It reflects the reserves. So that's the best test to confirm iron deficiency anemia. If it's less than 30, it's iron deficiency anemia. Now, one thing about ferritin that's very important is that it's an acute phase reactant, okay? That means that in an infection, inflammation, and so on, it will increase. It could be falsely increased, which is why it's very important to remember that it's an acute phase reactant. Okay, then coming to serum transferrin. Transferrin is the main iron transport protein. It's produced by the liver, okay? So iron deficiency, we will have increased transferrin. Why? Because it's going to be produced by the liver. It's going to be greater in number so that it can go all over the body and search for any iron that's available. In anemia of chronic disease, transferrin will be decreased. Now, transferrin is TIBC. I want you to remember this. However, transferrin saturation is completely different. Okay, so in iron deficiency anemia, what we have is serum iron is decreased, TIBC is increased, but the saturation is decreased because the body lacks iron. So even despite their efforts of going to find iron, it's still not saturated enough. Now, TSAT can also be falsely increased if there's iron intake, like recent iron intake, or hemolysis. Now coming to hemosiderin. Okay, hemosiderin is basically a water-insoluble crystalline iron protein complex. Okay, do you have to remember this? No, you don't. So it's found in macrophages. It's detected by pearl iron stain. Okay, hemosiderin is done on a bone marrow aspirate. Does that mean you do a bone marrow aspirate for iron deficiency anemia? No, it does not. So never do a bone marrow aspirate for iron deficiency anemia. However, if there's one done for any other reason, you have to make sure to do hemosiderin. And you'll see that if blue is present, that means iron is present. So we don't have iron deficiency anemia. However, if it's not present, then it's iron deficiency confirmed. Now, ferritin, I said, is the earliest marker. It's the most reliable test, okay? Now, in iron deficiency, we'll have low ferritin, low TSAT, high transferrin. Please remember this. In anemia of chronic disease, ferritin will be normal or high. Why? Because it's an acute phase reactant. And so on. Okay. Now, moving on. What are the findings? We said MCV, MCH, low, and high RDW. So, hypochromic microcytic anemia with high size variation, right? High RDW. It will have low reticulocyte count, low serum ferritin, and high TIBC and low TSAT. Okay, what I want you to remember from this slide is the peripheral smears, okay? So we'll have hypochromasia, which is like this pale center you can see, and they look lighter. And then we'll have target cells. You can see like it's like a bullseye right here. Then we can also see elliptocytes and pencil cells, okay? This is very important to remember because it can come as an OSPE question asking what are the key findings in a peripheral blood smear of iron deficiency anemia. Okay, now one thing I want you to remember is whenever you figure out through a CBC that a patient has anemia, what do? You need to find the underlying cause because if you find the cause, you will be able to treat it, okay? That's the most important thing to do. Okay, now I want to talk about why RBCs are microcytic in iron deficiency anemia. This is because there is an additional cell division that's taking place, which causes the RBCs to become smaller. But in macrocytic anemia, like megaloblastic anemia, there's one less division and it causes macrocytic anemia, macrocytic RBCs. Okay, now everything has stages, and so does iron deficiency anemia. So let's talk about the stages. So in stage 1, we have depletion of storage iron, okay? So it's the first thing that will happen is that the ferritin will decrease. At this stage, everything else is normal, but the ferritin is decreased. Then we have stage 2, iron deficiency deficient erythropoiesis, which is RBC production. So transferrin saturation is low and the TIBC is high because at this stage the body is trying to look for iron anywhere. So that's why it increases the TIBC. Okay. Now, ferritin is the most sensitive test. Please remember this. Now coming to stage 3. Stage 3 is full-blown iron deficiency anemia. At this point, you'll see the clinical features of patient presenting with pallor, with koilonychia, and so on. Now, in this situation, your HB is going to be low because it's the final stage, right? It's fully developed iron deficiency anemia. So your HB, MCV, MCH, everything will be low. And you will be able to diagnose hypochromic microcytic anemia. So you treat it with iron because that's what's needed as it's deficient. So we do iron replacement therapy. We give oral iron. And oral iron, it's 200 milligrams. Do you need to know the dose? I don't think so. I don't think he'll ask. But it's important to remember you give it for 6 to 9 months to restore the reserves. Now, we said ferritin was the first to go down, right? It's also the last to come back up. So it's in an opposite order, which I want you to remember. So the HB rises first, followed by all of these, and lastly, ferritin, which means that the full iron stores are replenished. Okay, now coming to anemia of chronic disease. Now, chronic disease, we know that there's something going on, right? So this could be inflammatory or it could be malignant. So it could be TB, it could be SLE, it could be Crohn's or malignancy, carcinoma, lymphoma, sarcoma, and so on. Now, let's talk about the lab findings. Okay, so HB low because of anemia, of course. MCV, MCH could be normal or slightly low. Serum iron and TIBC will be low. Transferrin saturation will be normal. And ferritin would be normal or high. Now, why will ferritin be normal or high? It's because ferritin is an acute phase reactant, I told you. And it's an increase in inflammation or infection. Now, let's talk about the pathophysiology. So there's hepcidin-mediated iron sequestration, which basically means that the hepcidin traps the iron, right? So what happens in inflammation? So we will have increased interleukin 6, and that will increase the production of hepcidin from the liver. Okay, now this hepcidin will block the ferroportin channels. Once it's blocked, the iron will not be able to go through, so it's trapped in the site of storage. And it will be less iron available for erythropoiesis. So RBC production will decrease all over the body. Then how do you treat this? Now, if you were to give oral iron, just like you did in iron deficiency anemia, will this solve the problem? No, it will not. Why? Because that would just be a band-aid and it would not even work. Now, iron therapy is ineffective, like I just said. So what do you do in this case? You find out the underlying cause and you treat that underlying cause and the anemia tends to go away. In some cases, we can give erythropoietin. Okay, now let's do a question. So a 47-year-old female has a 26-year history of SLE. Now, what does she present with? So she felt more fatigued, short of breath when exercising, and she's also menstruating. And let's see, she has a WBC of 3,700, HB of 10.2, hematocrit of 32, MCV 71. Now we can say this is either iron deficiency anemia or anemia of chronic disease, like our physician thought. So what do you do to confirm and figure out which one of this it is? So the thing you do is ferritin. Why do you do ferritin? Because in iron deficiency anemia, we talked about ferritin being low. In anemia of chronic disease, it would be high or normal. Okay, now coming to megaloblastic anemia. Now in megaloblastic anemia, we have defective DNA synthesis. Why? Because we have B12 or folate deficiency. This causes the problems with the DNA synthesis, and that causes macrocytic anemia, right? I said one less cell division in the RBCs, one less division in the RBCs, and that causes big RBCs. And it can also cause hypersegmented neutrophils, okay? So how is vitamin B12 absorbed? So the B12 enters via your food. It binds R binder, which is haptocorin, from the saliva. In the intestines, the enzymes remove the binder, and then B12 binds intrinsic factor from parietal cells in the stomach. Okay, intrinsic factor is produced by parietal cells in the stomach. It's very important to remember. Then this complex is absorbed in the ileum, and inside the ileal cells, it binds transcobalamin 2, and it's transported to the rest of the body. Now, what can be the causes of B12 deficiency? So first and foremost, we have pernicious anemia. Pernicious anemia is an autoimmune condition. There is autoimmune destruction of the parietal cells. Now, if the parietal cells are destroyed, that means the intrinsic factor will be low. Loss of intrinsic factor means that there's nothing left to bind vitamin B12. And this is most important to remember. Then we have gastrectomy. Now, gastrectomy is when a part of the stomach is removed. Now, if a part of the stomach is removed, that means you're also removing the parietal cells, right? So there will be no intrinsic factor to bind with B12. And there will be no complex formation. Then we can have ileal resection and so on. Now, one thing I want you to remember is folic acid deficiency or folate deficiency is very easy to develop. It can happen in a week or a few weeks. But vitamin B12 deficiency takes 3 to 5 years to develop, and it's seen in vegetarian or vegan people who don't supplement their diet with B12. Okay, now let's talk about the pathophysiology. So we said B12 and folate is something we need for DNA synthesis. Why? Because it's needed for thymidine production. If we have ineffective DNA synthesis, it will lead to macrocytes, right? So we will have a megaloblastic marrow, we'll have large RBC, which are macrocytes, and then we'll have hypersegmented neutrophils. I want you to focus on these, which are hypersegmented. I think we can see like 9 lobes here. Now, what does this mean biochemically? So B12 and folate deficiencies cause elevated homocysteine, okay? Both of these things together cause elevated homocysteine, but only B12 deficiency can increase methylmalonic acid. Okay, why? Because B12 is needed to convert MMA to succinyl-CoA, which is a cofactor. High MMA can cause accumulation of high MMA can happen in the anterior dorsal column of the spinal cord and lead to subacute degeneration. And this would produce neurological symptoms. Now, what I want you to take away from this slide is that overall, there's decreased thymidine, and that decreases DNA replication, defective DNA replication, and there's ineffective RBC production that causes macrocytes and megaloblastic anemia. Okay, now coming to pernicious anemia. We talked about that pernicious anemia is an autoimmune condition. Okay, we have antibodies that interfere with vitamin B12 absorption. Now, B12 can be absorbed because there's a lack of intrinsic factor from the parietal cells. Why? Because there's destruction of parietal cells. Okay, so we'll find pallor, low HB, MCV greater than 100 because macrocytic, hypersegmented neutrophils. We could also find leukopenia. Now, what will the test show? The test will show low B12 and positive intrinsic factor antibodies. So if they ask you what's one test you can do to figure out if they have pernicious anemia, it's intrinsic factor antibodies. Now, the diagnosis can be clinically done. It could be you could do a CBC, B12 levels, folic acid levels, and intrinsic factor levels. However, in a resource-constrained countries, we just give an IM B12 shot, wait a few days, and we see if the reticulocytes increase, which means that if there's a compensatory mechanism and the HB starts to increase, that means it was pernicious anemia. Now, the treatment is exactly that. You give intramuscular vitamin B12, and you have to give this for all of their life. Now, we can't give it orally because if we were to take vitamin B12 orally, it will go to the stomach and there's no intrinsic factor to bind to it. So there will be no complex formation and it will not be absorbed. Now, there are different types of pernicious anemia. I don't think this is very important, but I'll just cover it for the sake of complicity. So there's type 1, in which there's a blockage of B12 from binding to the intrinsic factor. Then there's type 2, which blocks the intrinsic factor and B12 complex from being attached and absorbed to the ileum, the ileal receptors. And there's type 3, which targets the gastric parietal cells. And we know that the parietal cells produce intrinsic factor. Okay, now coming to folic acid deficiency. So, in folic acid deficiency, first and foremost, where do we find it? So our sources of folic acid are green leafy vegetables, okay? But if you cook these vegetables, like spinach and so on, you're just destroying the folate. Now, it's absorbed in the proximal jejunum, And as I said, it develops in weeks. So it's useful for DNA, RNA production, replication. Now, most importantly, what I want you to remember, it is important in transformation in homocysteine and methionine. Homocysteine, methionine, okay? And this needs B12 as well. Now, what could cause folic acid deficiency? A poor diet, alcoholism, impaired absorption, which could be malabsorption, or it could be due to drugs like OCP, anticonvulsants. It could be an increased requirement like pregnancy, cancer, hemolytic anemia, where there's greater RBC turnover. And then we have impaired utilization. What does that mean? So if we have folic acid antagonists, if we're taking those like methotrexate, it basically inhibits folic acid, right, and antagonizes it. So this can cause a deficiency, and in this case, we will treat with folinic acid. Now, it's important to remember that in pregnant women, you need to supplement folic acid to prevent neural tube defects. And it's high risk in hemolytic anemias, alcoholics, elderly people to develop folic acid deficiency because the RBC turnover, because there's erythropoiesis. With increased hematopoiesis, folic acid supplementation is required. Okay, now coming to megaloblastic diagnosis. So what do you do? So first of all, you do a CBC, like always. You find no HB, anemia, high MCV, macrocytosis. So in the peripheral smear, you'll see exactly that. You'll see macrocytosis, you'll see hypersegmented neutrophils, and there'll be a low reticulocyte count. Now you need to figure out, was it the folic acid or was it the B12 that caused this? So what will we do next? You order the levels of B12 and folic acid, and that will give you your answer right then and there. But what do you do if they're both borderline or they're borderline? Then we do homocysteine and MMA levels, okay? Now, in B12 deficiency, both of these homocysteine and MMA will be increased. There will be accumulation because there's impaired conversion to succinyl-CoA, and that's what causes the neurological symptoms I mentioned. In folate deficiency, it will just be the homocysteine that's elevated. The MMA is going to be normal. Now, let's do a question. I said the dark red boxes are very important and they will come as a question. Okay, so a patient has borderline vitamin B12 deficiency. Sorry, vitamin B12 and folate levels. MMA is elevated. Homocysteine is also high. So they're both high. So we can say that this is a B12 deficiency. Okay, so what's the next step? You order intrinsic factor antibodies because you need to figure out if this is pernicious anemia. Okay, intrinsic factor antibodies, pernicious anemia. Always make that link. Okay, now the treatment. So treatment is just supplementation. Whatever is lacking, you supplement it. So in case of B12 deficiency, you give lifelong intramuscular vitamin B12. In case of folate deficiency, you give folic acid. Now, it's always important to rule out B12 deficiency before giving folate, because giving folate alone won't prevent the neurological symptom or damage, and it may worsen it. Okay, one thing I want you to remember, if B12 and folate levels are borderline, only then you do an MMA and homocysteine levels. Otherwise, it's not needed. Okay, now let's do questions. So a 32-year-old female, Asian female, is evaluated for anemia. Her HB is 8.7, her MCV is 104. So we know she has anemia and it's macrocytic. Now, serum cobalamin levels are normal, which means vitamin B12 levels are normal. Homocysteine levels are elevated and her MMA is normal. Which of the following drugs is known to cause this condition? Now, if both of them were elevated, this would be B12, but only one of them is elevated, which is why this is folic acid deficiency causing the megaloblastic anemia, right? Now, what drug can cause folic acid deficiency that I mentioned? Methotrexate. Why? Because methotrexate inhibits dihydrofolate reductase, okay, and that causes a folic acid deficiency. Other drugs are trimethoprim, phenytoin, and so on. Now, let's do the next question. A patient presents with a history of chronic alcoholism, okay, very important, presents with macrocytic anemia, thrombocytopenia. His blood smear shows oval macrocytes, hypersegmented neutrophil. A Schilling test is normal. What's your diagnosis? Now, The diagnosis is folic acid deficiency. Why? Because alcoholics is very common to develop folic acid deficiency, and we can see that he has megaloblastic anemia from the smear. Okay, now coming to hemolytic anemias. Now, hemolytic anemias basically means that there is destruction of RBCs. The normal lifespan of an RBC is 120 days. They're removed extravascularly by macrophages of the reticuloendothelial system. Okay, now majority of the RBC destruction happens in the spleen, then followed by bone marrow and liver. Now, how do you classify hemolytic anemias? The best way to classify it is either it's based or due to the membrane problem, enzyme or metabolic problem, or the problem with hemoglobin itself. Okay? Now, there could be intravascular hemolysis, which means inside the vessel, such as G6PD, or extravascular hemolysis, like in the spleen, like in the case of hereditary spherocytosis. Now, well, I want you to pay like a lot of attention to these two boxes because Dr. Rehan said he'll bring a lot of questions. Okay, now let's talk about bilirubin. So the liver has a limited capacity to conjugate bilirubin. Once this capacity is exceeded or overwhelmed, the excess stays unconjugated. Now, heavy RBC destruction increases the total bilirubin. Okay, so total, indirect, direct, everything will be increased. Now, LDH. LDH is an enzyme that's inside the RBC. Now, if there's RBC destruction, the RBC is going to blow open. So anything that's inside the RBC comes out into the blood. So that's why we have high LDH. Now let's talk about haptoglobin. So haptoglobin's function is to bind free hemoglobin. And in hemolytic anemias, there's excess free hemoglobin, right? So it's basically going to use up all the haptoglobin, and that's why haptoglobin is low. So low haptoglobin is a strong marker of hemolysis. I want you to remember this. Now, what happens if this capacity is exceeded? So eventually, there won't be any haptoglobin to bind the excess free hemoglobin. And in this case, what will happen? It starts spilling into the urine, and that causes dark brown or dark red urine, and that's called hemoglobinuria. Okay, now let's talk about signs of increased production. So RBC is being destroyed. The HB is low. And this signals the bone marrow to increase the RBC production. So the reticulocytes start increasing, right? Because there's increased RBC production. Nucleated RBC also increase. Then this would not be the case in beta thalassemia major. Okay, I want you to remember this. It's an exception. The reticulocyte count is not high here because there's ineffective erythropoiesis. Okay. Now let's talk about hereditary spherocytosis, which is one type of hemolytic anemia. So in hereditary spherocytosis, what happens is there's mutation in spectrin, ankyrin, and other like band 3, band 4.2, etc. And this causes an unstable membrane. If the membrane is unstable, fragments start coming out of the RBC, so you start losing membrane fragments. There's also reduced surface area to volume ratio, and the RBC becomes a spherocyte. The spherocyte then get trapped and destroyed in the spleen. Okay, this is very important to remember. Okay, and they also have a shortened RBC lifespan. Okay, now what do we have as the clinical features? You have anemia, you have jaundice because it's a hemolytic process which would result in jaundice, and we'll have splenomegaly. Why? Because their spherocytes are being trapped and destroyed in the spleen. So eventually, the size of the spleen will become huge. How do you diagnose it? You do flow cytometry of an EMA, which is eosin 5 malamide. It's basically a dye that binds to band 3, and it measures the content of the structural proteins. Okay. Now, the lab findings. We'll see reticulocytosis, we'll see increased MCHC, and we'll have spherocytes in the peripheral blood smear. One thing I want you to remember, if there's increased osmotic fragility, it's a very important lab finding for hereditary spherocytosis. Okay, dark red box again, which means it's very important. So what type of hemolysis is seen in HS? We talked about it's extravascular. Why? Because it's happening in the spleen, causing splenomegaly. Now, how do you differentiate between autoimmune hemolytic anemia and hereditary spherocytosis? Now, in autoimmune hemolytic anemia, that is positive, and hereditary spherocytosis, that is negative. Okay, this is important because it's hard to differentiate between them since they're both hemolytic processes. Now let's talk about G6PD deficiency. So let's talk about the pathophysiology first. So we have decreased G6PD, and there's cell lysis, and there's increased oxidant exposure. This causes Bite cells, which is basically removal of Heinz bodies. And this is an X-linked disorder. Now let's talk about the clinical features. So it's asymptomatic or episodic hemolysis. What does that mean? That basically means that there are certain triggers that are here that can cause G6PD to exacerbate, right? So some of the triggers are broad beans such as favism or fava beans. There's drugs such as antibiotics and aspirin. G6PD deficiency is a self-limiting disorder, okay? That basically means that if you remove the trigger itself, the G6PD deficiency and the symptoms will go away. Now let's talk a little bit more about Heinz bodies, such as the ones I've showed by the pictures here, because diagnosis is based on Heinz bodies and Bite cells. So Heinz bodies indicate denatured globin chains, which is very important to remember. And Bite cells present as, imagine you took a bite out of a donut, that's what a Bite cell looks like, which is very important to remember, okay? Not the donut part, the Bite cell part. Okay, so why do G6PD deficient red cells die? It's because there's oxidative damage, because we said there's oxidant exposure, right? And they can't remove free radicals. So the hemoglobin basically breaks, the heme falls off, and the globin degenerates, and that causes Heinz bodies. Now, in the process of Heinz body's formation, the spleen recognizes it and tries to remove the Heinz body, and that causes Bite cells, which are seen here, and that causes hemolysis eventually. We can see that this patient has jaundice, and which is most prominent in the sclera. Now, when a G6PD deficient patient experiences a crisis, do you check the G6PD right then and there, or do you wait? So the recommendation is to wait 4 to 12 weeks to repeat the test. Why? Because there are false negatives that can happen. So the bone marrow compensates for the anemia by increasing the RBC production, and that causes high reticulocytes, and which can elevate the G6PD levels. Okay, now let's talk about autoimmune hemolytic anemia. Now, this is basically an autoimmune process. There's an antibody production against its own cells, okay? One thing I want you to remember is it has a positive DAT, okay? Positive DAT in IHA. The clinical features are similar. So we have fatigue, pallor, jaundice, splenomegaly, and hemoglobinuria, causing red or dark brown urine. Now, there's two types of autoimmune hemolytic anemia. There's warm, which can happen at 37 degrees, or it can be cold at 4 degrees. Now, what can be the cause of a warm IHA? So it could be idiopathic, secondary to SLE, and so on. One thing I want you to remember is the pathology, okay? So what happens is the IgG coats the RBCs, the spleen recognizes these coated membrane RBCs, and it tries to take it out, basically, engulf it, and remove it. And this causes loss of membrane and spherocytes. So mostly the hemolysis is extravascular, okay, because this is happening in the spleen. So that causes splenomegaly. When IHA and immune thrombo ITP occur together, it causes Evans syndrome. Now the lab findings is spherocytes, nucleated RBCs, and polychromasia. There is no haptoglobin, spherocytes are present, and that is positive. Very important to remember, that is positive. Then we have cold IHA. It's more in women than men. Now, what's the cause of it? IgM. I need you to remember IgM. That's all I need you to remember. Cold IHA, IgM. Now let's talk about the pathology. So IgM binds in the cold and causes complement C3b to coat the RBC. That causes intravascular and extravascular hemolysis. The DAT here is positive for complement only, okay? So C3b is basically an opsonin. And opsonin are proteins that tag certain things so that the macrophages can come get them and phagocytose them, basically. So the features here would be chronic hemolysis that get worsened by the cold because it's cold IHA. And there's jaundice, splenomegaly, and acrocyanosis. Now the labs would show less spherocytes, and that will be positive for C3 plus only. So the treatment here is keep the patient warm. That's simple. You could also give rituximab or plasmapheresis, but rituximab is more like a second or third line therapy, so it's not very essential. Now, coming to splenectomy. Now, splenectomy is beneficial in warm IHA only if they don't respond to steroids, and steroids is the first line therapy. Now, what is that we've been talking about for the past 2 slides? Is direct antiglobin test, okay? It demonstrates the presence of antibodies or complement on the surface of the RBC. Now, in warm, I want you to remember these 3 lines. So warm or cold, what test do you do? Monospecific Coombs reagent. If you do one reagent with IgG and it's positive, it's warm. IgG, warm. If you do one with C3 and it's positive, it's cold. So IgG, warm, C3, cold. Okay? Okay, now let's do a question. So a 36-year-old Caucasian female presents to the ER in acute distress, pale, short of breath, easily fatigued. Her vital signs show, let's just skim over this. So her physical examination show yellow discoloration of her conjunctiva and a palpable spleen, which would not be in this case, like it's not a normal finding. She has a history of cholecystectomy at age 25. Her father and paternal grandmother had a history of anemia. Her doctor diagnosed her with hereditary spherocytosis. Of the following, what lab test do you do? So the lab test that you will do is osmotic fragility testing. It's very important for you to remember this, okay? Because it will be consistent with hereditary spherocytosis. Okay, now let's go to the next question. A 23-year-old man presented to his physician 2 weeks ago with a non-productive cough and malaise. He was treated with azithromycin for walking pneumonia due to mycoplasma pneumonia. He now has fatigue, he has pallor, his RBC count is decreased, he has polygomatophilia, and he has an increase in indirect bilirubin. What are the lab tests going to show? The lab tests are going to show acute cold agglutinin disease. So it's a form of hemolytic anemia that we talked about because autoantibodies are produced to the blood group, and it basically can sometimes cause mycoplasma pneumonia infection, which is very important to remember. So cold IHA mycoplasma pneumonia infection is a common complication. Okay, now let's talk about our last lecture for today. So out of the molecular bases of hemoglobinopathies, what do you need to know? So let's just briefly go over it. So structure and how it works. Hemoglobin is an RBC protein carrying oxygen. What I want you to remember is that it has 4 subunits, okay? 2 alpha chains and 2 beta chains. Now, each goes and binds with heme, okay, which is Fe2+. Heme binds oxygen, Fe2+ attaches to the globin histidine. There's 2 forms, TENS, which is deoxygenated or tight, and there's R, which is relaxed, oxygenated, and loose. Now, globin imbalance causes unpaired chains to precipitate, and that can damage RBCs. Now, what I want you to remember here is the fact that chromosome 16 has alpha globin genes, okay? Each person has 2 genes on each chromosome. So that means 4 alleles in total, okay? Now, in chromosome 11, we have beta globin genes. So each person has 1 beta gene on each chromosome. So that would total 2. Fewer beta alleles cause beta thalassemia, which is more common. Okay, I want you to remember that. Why this matters for thalassemia is because thalassemia is caused by mutations that reduce or eliminate globin chain production. Now, let's talk about the second box. So we have hemoglobin development and mutations. So in an embryo or in a yolk sac, which is basically the first 3 months, we have these types. So we have Gower 1, which is the first hemoglobin made in the embryo, then 2 and 3 and so forth. Then we have fetal hemoglobin, which is HbF. Now, fetal hemoglobin has a higher oxygen affinity than adult hemoglobin. Why? Because the fetus has to extract the oxygen from the maternal blood. This is produced mainly in the liver, and then eventually it's also produced in the bone marrow right before birth. Then we have the adult hemoglobin, so HbA, which is the main hemoglobin, HbA2, which is 3%, and HbF, which is 2%. Now, why the timing of the expression matters? So alpha chain is expressed early. That means it affects the fetus prenatally. Beta chain, it's after birth, so postnatally. Now, let's talk about mutations. So mutations are just alterations in the base sequence, and there are different types of mutations. Silent mutations causing no effect, missense, which means one is changed only and it can possibly affect, and then nonsense causing a truncated protein. Now let's talk about hemoglobinopathies. So it's basically inherited disorders affecting the hemoglobin quantity or the structure. So quantity or structure. So it can be a quantitative defect, which can be decreased globin production, such as in thalassemia, or it could be the quality of it, such as the globin structure is just abnormal in sickle cell anemia, HBS, sickle cell anemia, for example. Now, the common mutations is HBS, and this can cause sickling in vaso-occlusive crisis, or HBC, which can just cause mild hemolysis. Now, one thing I want you to remember, I'll just briefly mention the mutations. I don't think that it's too important to remember, but just for the sake of complicity. So we have different types of hemoglobin mutations. So we have missense mutation, where an amino acid changes and it causes altered HB function. Then we have a silent variation or silent variant, which is a genetic change that causes no effect on the phenotype. Then we have unstable hemoglobin, which can cause precipitation and Heinz bodies and hemolytic anemia. Okay, now coming to sickle cell disease. Now, sickle cell disease is just when there's a genetic mutation on the beta globin chain. So at position 6, valine replaces glutamic acid. Okay, this is very important. So this is HBS. Now in HBC, the same position 6, lysine replaces glutamic acid. Now what does all of this cause? What does this replacement cause? Now it causes decreased solubility of deoxy-HBS. The oxygen affinity decreases. What does that mean? There's a right shift in oxygen dissociation curve. Now this curve is very important. The black line represents the normal, the blue line represents the left shift, and the red line represents the right shift. Okay, now what does this cause? So there can be RBC sickling, which is basically loss of flexibility, because as you can see, they're sickle shape, right? They're rigid, they're sickle shape, and they can get trapped. Once they get trapped in the vessels like this, it can cause a vaso-occlusive crisis, and it can also cause organ damage. So sickling is worsened by low oxygen tension. Now, one thing I want you to remember is that there can be microvascular occlusion as well. So small occlusive crisis, basically. And that can cause hypoxia, infarction, and sickle cell crisis. Now, sickle cell disease or sickle cell anemia is prevalent in African people. So whether that be African Americans or the Western Africa. Now, let's briefly go over the differences between HBC, HBSC, and HBE. So HBC, the glutamic acid is replaced by lysine. There's decreased solubility. However, the patient is usually asymptomatic because it's basically like a milder form of the disease, right? So the lab findings would show reticulocytosis, HBC crystals, target cells, fragmented cells, and we can diagnose this on hemoglobin electrophoresis, which we'll talk about. Then we have hemoglobin SC disease, which is compound heterozygous. So it has one S, one C, but the HbA is absent. Okay, then what can this cause? It can cause mild sickle cell-like symptoms, like a vaso-occlusive crisis. How can you differentiate? Because this has prominent splenomegaly way more than in HBS disease. The lab findings will show normal chromic normocytic anemia. Then we have HBE, which is glutamic acid is replaced by lysine. It's slightly unstable, and this is more common in the Asian nationalities. Okay, now coming to thalassemia. Now we have different types of thalassemia. So alpha thalassemia, let's use this table to our benefit. So we have alpha thalassemia, and normally we'll have 4 alpha genes. And this, all 4 present means that there's no anemia, right? So let's talk about silent carrier next. So silent carrier is when we can see that there's 3 present but 1 absent. So 1 gene is deleted. This doesn't really cause any symptoms, so the HB is usually normal. Then we have alpha thalassemia trait. In trait, we have 2 gene deletion. It can cause mild anemia, but the rest of the alpha genes can compensate, and that would just make it a mild anemia. Then we have HbH disease. Now, this is a more severe form than the ones that we talked about. Now, what happens in this is that there's 3 genes deleted. There's too few alpha genes, so no compensation can take place. And what happens is that we have intermediate anemia, which is very important to remember that this is just a moderate anemia. Then we have hydrops fetalis. Now, hydrops fetalis is basically when all 4 genes are deleted. Okay, there's no alpha genes, so the gamma 4 tetramers start like forming, and this is called HB Barts. And this is lethal in utero, which means it's not compatible with life. Now let's talk about beta thalassemia. Now, beta thalassemia, normally, as we said, we have 2, right? So if both of them are present, it's just the normal case. Now, what happens if we have thalassemia minor? In thalassemia minor, we have reduced beta chains. So there's mild anemia, but the HbA2 and the HbF compensate the increase, and they compensate for this. Then we have thalassemia major. Now, in thalassemia major, what happens is that it's a very low or almost absent beta chains. So there's severe anemia, and this cannot be compensated, but the HbF still tries. Then we have hereditary persistence of fetal hemoglobin. We said HbF is basically increased here to reduce the severity of the anemia. Okay. Now, this is a clear table for alpha thalassemia. So silent carriers will have a silent picture, right? So they won't have any symptoms. Alpha thalassemia trait, which means 2 genes are deleted, will have mild hypochromic microcytic anemia. Then in HbH disease, we have mild hemolytic anemia, and in hydrops fetalis, it's unfortunately incompatible with life, and it will be death in utero. Okay, then we have hemoglobin H disease. Now here we said 3 of 4 alpha genes are mutated. So there's a high beta to alpha globin ratio, right? So we have formation of HbH, which is beta 4. The clinical features will be microcytic anemia, sphenomegaly, jaundice, and iron overload. Now, what do I want you to take away from this? Because there are fewer beta alleles, mutations in beta genes cause diseases more easily, okay? Making beta thalassemia much more common than alpha thalassemia. Here, all I want you to focus is that this is a peripheral blood smear. It's stained with crescel blue. And here it shows that there are precipitated HbH by the blue. Okay, now coming to beta thalassemia. Now, beta thalassemia is very important because they're more likely to ask you about this. So beta thalassemia, there's underproduction of the beta globin chain. So in trait, we have asymptomatic because the beta globin is reduced. If it's reduced, it's B+, okay? If it's absent, it's B0. Most of the times, what happens here is it's reduced, so it should be still sufficient enough. That's why we call it trait. There's not too many symptoms. There's barely noticeable, basically. Then we have beta thalassemia intermedia. So here, both will be reduced, okay? So this would result in moderate anemia. In beta thalassemia minor, you will have 1 normal gene and 1 reduced gene. Then let's come to beta thalassemia major. Now, in beta thalassemia major, there's a significant reduction in the beta globin chain. Okay? So what happens is that the body can partially compensate for the loss or complete absence of beta chain production by the other allele. So the clinical features, we have severe anemia during the first 2 years of life, hepatosplenomegaly, growth failure, jaundice, and thalassemic phases, which is very important to remember because some of the clinical vignettes on the questions can tell you about extramedullary hematopoiesis, which causes thalassemic phases. This results from marked bony changes from bone marrow proliferation. Now, what are the important lab tests to run? We do CBC, and that will show anemia, microcytosis, and thalassemia. We do a blood smear that could show sickle or target cells and so on. And we do hemoglobin electrophoresis so that we can quantify or see what is present. Is it HbA or HbF and so on. We basically want to quantify it. Okay, now coming to methemoglobinemia. Now, what happens here is it's caused due to the oxidation of hemoglobin iron from Fe2 plus to Fe3 plus, okay? Now, Fe3 plus cannot bind oxygen, so there's reduced oxygen delivery, and it comes up as this like blue, brown, like purple kind of blood when you take a blood sample, and the patients appear cyanotic because they have reduced oxygen delivery. The PaO2 is usually normal, and this can be either congenital or acquired. Now, let's talk about hemoglobin electrophoresis. Now, when we took this lecture so many years ago, this was given by, I think, Dr. Rihan, and his favorite questions were about electrophoresis. Now, what happens at electrophoresis? So, this is the setup. A gel is placed basically between a cathode and an anode. Cathode is negative, anode is positive, and a power source is applied. What does this do? So hemoglobin, all sorts of hemoglobin, whether that's A, S, C, and so on, they're all negatively charged, okay? So they migrate towards the positively charged anode. And how fast that migrates, we can basically calculate the area and we can take a guess or quantify it and find out which is most present. So let's see here. We have HbA, which is normal adult hemoglobin, right? It moves at a standard rate and it moves fast. HbS is behind it, which means this is slower. It's taking, like, this goes fast, it's taking longer for it to get here. Now, it migrates slowly because there's a beta S mutation that alters its charge, so it's not very strongly attracted to the anode. Then finally, we have HBC, which migrates differently because there's a beta C mutation. By comparing the positions of A, S, C, we can diagnose the different hemoglobinopathies. However, in the lecture that Dr. Al-Jada gave this year, he said something which I think is of importance. So what we do now is that we run a chromatogram. It basically scans these bands, and then the software generates a chart, and it calculates the area under each curve. And with that, it determines the proportion of each hemoglobin type based on the area itself. Okay. Now coming to our final questions of the day. So we have a 10-month-old boy of Arabic. He's just Arab. I don't know why this question phrased it so weird. He's brought to the physician by his parents, complaining that the child is failing to thrive. Very important to remember. Physical examination reveals splenomegaly and jaundice. CBC shows microcytic hypochromic anemia. Very important. Which of the following best describes the pathogenesis of splenomegaly seen in the patient described in the question? Now, we can see here that the patient has, from the peripheral blood smear, he has beta thalassemia major, right? So the child has microcytic hypochromic anemia, he has jaundice, splenomegaly, and failure to thrive. This is classic for beta thalassemia major in an infant of like the Middle Eastern origin. So the correct answer here will be extramedullary hematopoiesis. Okay, now coming to the next question. One thing I would also like to mention is that when the bone marrow, the body tries to compensate by massively increasing erythropoiesis. This causes extreme bone marrow hyperplasia. okay? Expanding the marrow cavities and producing skeletal changes. Sorry about that. So, as I was saying, this causes extreme bone marrow hyperplasia, expanding the marrow cavities and producing skeletal changes. This is what causes thalassaemic facies. So, there's frontal bulging, there's maxillary overgrowth, and when the marrow cannot keep up with this hematopoiesis, it starts happening in other organs, such as the liver and spleen. And this is called extramedullary hematopoiesis. This is all what I want you to remember from this question. Now, coming to the last question for the day. So, a 10-year-old black girl is brought to the ER. She complains of severe pain in her chest, abdomen, and bones. Physical examination reveals jaundice and anemia. Her parents state that she's been anemic since birth, okay? Her CBC shows normocytic anemia with marked poikilocytosis, which I told you it's a difference in sizes, right? A peripheral blood smear is shown. Okay, hemoglobin electrophoresis demonstrate H hemoglobin S. So we know that this patient has sickle cell disease, right? Because she has hemoglobin S. Now, what's happening here? Why is this patient coming with severe pain in her chest, abdomen, bones? It's because she's having a sickle cell crisis. And when does a sickle cell crisis happen? It happens when there's ischemia to organs. So the answer here would be D, ischemia. Okay. Now I have combined all of the lectures of all of the anemias and the molecular bases basically into a table that is very good for a quick review. So the morning of the exam, you just want to look at the keywords and you want to figure out what you can use to solve the questions. And this is what I also used, and it has helped me a lot in heme. So I would recommend this highly. And that's all I have for my session. I hope you guys enjoyed it. It was my first PAL session, and I had a lot of fun making the slides and helping you learn. So thank you so much. Feel free to share some feedback for this session, and I wish you the best of luck for this exam. Inshallah, you'll do great, and good luck. Thank you so much.